So my name's Bree, I'm an occupational therapist. So we're going to talk a little bit today about the occupational therapy role within cancer survivorship and how we interact with our clients. Next slide is the objective. So what we're looking to get out of today, so understanding the role of an occupational therapist within cancer survivorship models, learning about various interventions that we can implement with our clients and how and when to refer to occupational therapists. So cancer survivorship can begin at diagnosis, and studies report an underutilisation of occupational therapists in cancer-related care. It was found that around 87% of older cancer survivors were considered to be in need of OT, however, not that full extent of clients actually received the care that they needed within the first 2 years of diagnosis. And cancer-related fatigue is, I've noticed, one of the biggest things that I work with when I'm working with oncology and cancer clients, with as many as 60% of people receiving cancer treatment. Beautiful. So what is cancer survivorship? So many of you would know there's lots of different definitions out there, and it can mean different things to different people. So one of them might be having no signs of cancer after finishing treatment, and another might be living with, through and beyond cancer. So in Australia, we're recognised from diagnosis typically. And I guess what's common is cancer survivors are obviously growing in number, and we need to recognise the ongoing and unique needs of each individual. Survivors are often left with a compromised quality of life as well, whether that be functional or physical. And also it's important to note that some clients do report positive psychosocial effects after receiving a cancer diagnosis, and that might be around strengthened relationships, having a sense of gratitude or empowerment, or an increased appreciation for life. So these are just some common concerns that I've seen during my work as an occupational therapist. So things from anxiety and depression, anxiety around going to see specialists before going to the GP, uncertain about follow-ups, finding a new normal particularly being a big one. Many experience a lot of financial, family stresses, emotional changes, worried about the effects of treatment and how that can impact them functionally and physically as well. So the lack of survivorship care. So that can exacerbate or prolong any physical or cognitive or even emotional changes and affect the appropriate treatment. It can result in activity and participation limitations, so being restricted within their daily activities, having a loss of self-efficacy and independence, and it can also take a toll on the families and caregivers in terms of lost time, lost money, lost productivity, and also emotional distress. Beautiful. So potential health needs for cancer survivors. So looking at many different aspects, so that might be things such as psychosocial aspects, for instance, anxiety, depression, addressing isolation as well, addressing the negative impact on self-identity or their self-image, continence, nutrition, functional impact, so the physical effects experienced that might include pain or musculoskeletal issues, fatigue, breathlessness, lymphedema, and the list goes on. So with the OT role, we're just aiming to optimise someone's quality of life and promoting occupational performance through their engagement and participation in meaningful occupations. So working out what's important for the client. Assisting with symptom management, so through assessment, education, redesigning what tasks they're doing, prescribing equipment, providing assessment on their ability to safely manage within their own home, so looking at doing home assessments, and providing support, education and training to formal and informal caregivers to reduce the risk of injury to themselves and to the client, reduce the risk of negative experiences and complex bereavement as well. And just having that understanding that the informal caregiver role can be quite challenging and it can generate anxiety and stress as well. Okay, So the therapeutic interventions are designed to address impairments and improve function and wellbeing. So aiming to maintain their level of function and their independence as well to the level which they would like to be at. Providing adaptations and advice to the clients and also to the carers so that the individuals can do what's important for them, so what their goals and their aspirations are. Assisting in the development of supportive relationships and also utilising coping strategies effectively. And also helping them to reconnect with leisure activities, engaging in the community, engaging in employment and in education. Beautiful. Okay, so just some principles about occupational therapy. So looking into client-centred evaluation. So gathering an occupational history of the client and emphasising their strengths with what they're doing and also looking into their coping strategies. So seeing what strategies they've already got in place that are working effectively for them. And assessment of limitations in various occupations or roles. So what areas are they not performing to where they were previously? Looking into holistic treatment plans to improve various symptom-specific problems and occupational-based issues. So that might be through energy conservation, coping techniques, relaxation strategies, for managing things such as pain, fatigue, sleep difficulty as well. Engagement in exercise or leisure programs. So that might be working to improve strength or mobility in the client, helping them to remain at home as long as able. Looking at cognitive strategies, activity adaptation, assistive technology to optimise their performance. Looking into some support groups that might help them work through their situation. And looking into lifestyle consultation for enhancing health and quality of life. Beautiful. So being OT, we're all about someone's engagement within their occupations, and that's obviously dependent on their barriers and facilitators within whatever environment they're working with. So we need to work timely to identify and implement any interventions aimed at enabling their health and their wellbeing. The research evidence at the moment seems to be highlighting that with chronic diseases, they might be best managed by having a balance of traditional medical care and day-to-day practice of self-management skills by the client. So from an occupational participation perspective for therapists, we're managing their functional changes within their activities of daily living, but we also need to consider the survivor's perspective as well. So what their goals are, addressing their view on what ADLs or activities of daily living are meaningful to them. So having that conscious input of cancer prevention, health promotion, and also wellness after cancer. Yep. So the common thing that I seem to come across working with clients who are undergoing cancer treatment is, okay, they're at their end of life, we need to organise X, Y and Z to help them remain at home. But the interesting thing is that we can work in all different sorts of settings, particularly from diagnosis. So it's not necessarily at that point that occupational therapy can become involved. So we work with cancer clients through many different settings. So that might be in an acute setting, in a rehabilitation setting, as an outpatient or doing management at home, so home care. And we also work in hospice and palliative care. And some therapists also work in exercise and wellness programs or groups as well. So our typical intervention with a client would look at doing an initial assessment, so gaining an insight into their previous level of function, gaining information about their home environment, their interests, and their perception of any anticipated functional difficulties that they might have after discharge from hospital. Looking at their assessment, or looking at doing an assessment of their transfer, so how they're actually going at home, so getting on and off the bed, chair, bath, shower, toilet. Assessing their domestic tasks at home, so that might be making the bed, engaging in meal preparation, and sometimes we even complete most of this from an initial home visit. So going and seeing how they actually function within their home environment rather than in an unfamiliar setting. And most importantly, liaising with the multidisciplinary team, so whether that is cancer support nurses, physiotherapists, GPs, specialists, to make sure that the care we're providing is holistic for the client. So cancer-related fatigue is reported from diagnosis during medical treatment and for months to years after completion of treatment, which makes it one of the most prevalent symptoms reported. So the primary goal is to reduce the fatigue that interferes with their daily activities, and it varies in frequency as well. So around 30% of individuals diagnosed with cancer might experience moderate or severe cancer-related fatigue in the first year after diagnosis. And cancer-related fatigue management, it's appropriate across all rehab paradigms as well, and across their continuum of care, all the way from that initial screening to survivorship through to end of life, and basically everything in between. And it's something that does limit the client's occupational performance levels and their quality of life, so it can affect what tasks they want to engage in. So some intervention examples that I might do with a client are looking at grading any activity and exercise that they're doing, providing them with education around saving their energy, covering relaxation and sleep hygiene, so looking at having structured sleep patterns and some cognitive rehabilitation as well. And it's important to note that in any intervention we must consider all aspects, so the physical, the cognitive, the social and the psychological dimensions as well. Cancer-related cognitive impairment. So cognitive impairment in general can impact on a return to any role, and it affects a person's perception of their ability to participate in any functional activity. And cognitive impairment is associated with reduced productivity, engagement in social and community tasks as well. So some intervention examples that we would look at are doing functional assessments, cognitive assessment, establishing whether they can cope safely at home, and a big factor of that is whether they're living at home by themselves or whether they have appropriate supports in place. And then working with the client, family or carers or their multidisciplinary team to ensure that we're achieving the safest solution as possible to help them achieve their goals. Peripheral neuropathy. So looking at the injury or inflammation to the peripheral nerves. So there are many symptoms that can be experienced by a client that has that, and it can impede most of their activities of daily living and their engagement. So they might actually withdraw from doing tasks that they would like to do. And stress due to chemotherapy pain can impair healing as well. So some intervention examples. So we might look at doing a sensory assessment to determine what deficits they have and monitor the changes that they're seeing. So actually monitoring to see whether it's stable or whether it's progressively worsening. Providing exercises for strengthening or proprioception, fine and gross motor coordination skills and balance training. While there's not necessarily any evidence that supports that exercises can improve those symptoms, it's been shown to reduce the likelihood of falls and improve overall performance within some activities of daily living. Providing education around skincare, hand and foot safety as well, due to the lack of sensation. And one of the most common ones for us is equipment prescription to aid proprioception, so making sure they're safe around the home. Breathlessness. I guess the main thing is needing to determine the cause of the breathlessness. So our intervention looks at exploring the meaning to the individual, the family and the carers involved. So looking into the triggers around that, any fears, patterns, role changes, the effect on the families and carers that it's experiencing it, enabling activities to achieve optimal independence. So looking at activity analysis, different strategies, assessing the home environment. It might also be around providing aids and adaptations to the environment. And the last one, managing anxiety and panic attacks. So providing education around that, some strategies to regain control and looking at goal setting also. Anxiety management and relaxation. So looking into the management of the stress response. I guess looking at a management assessment enabling us to explain the anxiety reaction and why the individual is experiencing any difficulties with this. Looking at challenging their negative thinking, encouraging positive phrases for stressful activities. Relaxation techniques is probably the biggest one that I look at as an occupational therapist. So that might be things such as imagery, progressive muscular relaxation, or a release-only technique, and controlling over-breathing as well is very important. Okay. Cancer-related pain. So it's estimated that around 30 to 50% of clients will experience some level of pain. And pain, or an increased severity of pain that's not controlled or isn't well controlled, has been shown to correlate with poor performance during daily activities. So some interventions to facilitate improved quality of life might be establishing the effects of pain on someone's ability to function, setting goals and priorities for the client and enabling a grading process, establishing how it affects their family dynamics as well and their roles within the family and their capacity to lead a productive life. And again, looking at any sort of equipment prescriptive techniques that might help to aid independence or particularly comfort for the client as well, given that they are in pain. Okay, so lymphedema. So looking at activity analysis from an occupational therapy perspective to address any challenges that the client might have, and aiming to promote independence. So we generally do refer to the lymphedema clinic, or we do have a lymphedema physiotherapist at the hospital, so we might refer to Georgie or we refer to the Bendigo Lymphedema Clinic. But we do look at providing advice on energy conservation, any safety issues as well, equipment prescription, and we also look at bandaging and compression garments as well, and going through skin care, assessing mobility, transfers, how they're going getting around. Okay, so psychosocial issues. A lot of this was covered by Alice earlier. So it's estimated that 1 in 4 people with cancer experience some sort of clinical depression or anxiety. And this is something that we encounter a lot, so we would look at referring on to someone like Alice, so a psychologist or a counsellor, to help guide them through that process, as lasting psychosocial or psychological burdens have been found to increase their difficulty in re-engaging in the tasks that they would like to perform. So that might be such as any sort of leisure activity, socialisation, even sleep. So end of life. So this is primarily where occupational therapists are thought to come in. So it's about continuing participation in meaningful activities for the client and using different sorts of strategies to reduce their symptoms. We might be looking at environmental adaptations or prescriptive equipment to improve their quality of life and that of their carers or of their family. Goals might be related to their physical function, so their ability to shower themselves or to go to the toilet, those sorts of things. But most seem to be more about spending time with their loved ones and making preparations for that end of life stage. So some interventions that we might look at completing are things such as making a bucket list or creating a memory box, so that way the person can leave I guess, part of themselves behind to share with their loved ones. We might do a basic assessment of daily activities, but I guess at this stage we wouldn't normally look at doing a comprehensive assessment due to the focus of their goals being elsewhere, and typically looking at pressure management as well. Creative therapies, so that does fit a lot into end of life, but it also fits all along the continuum of cancer survivorship. So it can be considered in many ways. So it can be thought to help enhance communication, and it can allow emotional expression for our clients. So that can be verbal or non-verbal, whether it's writing, painting, craft making, and it can encourage them to actually reflect on where they're at within their life. They might look at creating gifts to express their emotions and how they're feeling. And it can also affect their emotional closure and, I guess, regain a sense of control for that person. So the occupational therapy challenges of treating cancer survivors comes from a lot of different aspects. And I know my profession isn't the only one that feels that. A lot of the time having conversations with people that might be towards end of life or have that uncertainty about their diagnosis can be quite challenging. So a lot of it is about communication, so learning to cope and deal with the conversations around death, providing that education to the family in anticipation of functional or physical general decline, any contraindications when undergoing treatment, particularly the difference between cancer care and traditional therapy. So with a client who is not or does not have a cancer diagnosis, I might look at doing a full functional assessment, so assessing how they're going with their domestic and community activities of daily living, whereas someone with cancer might have completely different goals. So narrowing it back down to their basic function, how they're going with their transfers, how they're getting around, and what are the smaller tasks that they want to be able to achieve. The emotional side of things as well, so how it affects us as therapists and dealing with someone whose diagnosis might be uncertain. Care burden. I know Alice touched on this, and every therapist brings their own little, pod to the table. So 1 in 10 people provided hands-on care for someone at the end of life in the past 5 years. A lot of the tasks are associated around household tasks. So that's around 68.5% through one of the studies that I read. A lot of emotional support throughout this time of their life, and money and financial management. And a lot of carers can find difficulty with their coping strategies and adjust to their new roles and routines whilst caring for someone with cancer. So things that someone might assist with include communication, taking someone to and from appointments, managing personal care, helping to coordinate their healthcare as well, and managing the appointments. So the impact on caregivers, there's a lot. So I've just listed 10 here, but the list is extensive. So feeling lonely, feeling like they always have this need to be attached to help, their inability to work, or they might reduce their employment to care for someone else, which might result in financial burden as well, increased morbidity and mortality rates, an increased risk of anxiety and depression. That can also stem from the loneliness or social isolation that they might be feeling. Fatigue, general pain if they're assisting with transfers as well, and a loss of physical strength. So supportive care interventions. So we might look at doing some skills training with them. So teaching them different strategies around how to cope, how to communicate, and how to problem solve through this point in time. Linking them in with some therapeutic counselling and doing some psychoeducational analysis. Or looking at self-help, supportive care interventions. So if someone is clearly, suffering from carer burnout or stress and they're not willing to accept any help, just providing them with the appropriate resources. So there are some coping skills workbooks and education fact sheets that we can provide, or also looking at giving them hotline information, so that way when they feel comfortable or they feel it's appropriate to reach out, they can look at doing that independently. So self-management. So looking at assessing to determine someone's willingness to manage their cancer care themselves. So providing tailored information can increase knowledge and prepare them for any sort of change, and it should be provided for all clients as well. So that might include helping them to manage treatment schedules, side effects, any emotional turmoil, and family dynamic changes. So some examples of how these skills can be provided might be through group sessions or attendance at those, one-on-one interactions with your client, or also by providing some technology links in that way. So things that clients need to help manage their cancer care independently include having the right practical and emotional coping skills, helping them to overcome the physical effects of cancer and its treatments, helping them to understand the need to make lifestyle changes which can help enhance their own health and wellbeing, providing them with the right education to ensure that their skills and knowledge about monitoring their own risk of recurrence, and giving them the support to know where to get advice and how to gain it when it's needed, and enabling them to access the right education and information, about the tasks at hand. So some local referral options. So you can be referred to occupational therapy at any stage across the cancer continuum. So in hospital, it typically is by like a patient flow manager or liaison with the bed manager. My Aged Care spot tools. For clients over 65, it is typically My Aged Care, and I understand GPs generally have their own program as well for referring, their own ways for referring. And Connecting Care is generally used for clients under 65. So I guess in conclusion, cancer survivorship does start from diagnosis, and OT intervention can be required at any stage from diagnosis to end of life or bereavement. Making sure that we have a focus on someone's quality of life and their goals and what they want to achieve. And just addressing carer burden through promotion of self-management, providing them with service involvement and supportive care services as well. And that's it.